Okay, this is the final chapter of the book, Chapter 33, Maintenance for the Periodontal Patient. So long-term success requires post-treatment appointments. So oftentimes patients are confused and think that um, having periodontal treatment is like fixing a broken bone, where you go to the doctor, you have a broken bone, you go to the doctor, they do some treatment and it's fixed, and then they're done for good. Uh, they seem to think periodontal disease works the same way. You go to the dentist, you get your treatment done, and you're fixed, or you no longer have disease. And so it's important as the hygienist that you stress to the patient the importance of continuing their maintenance care at a regular interval. They are no longer now a regular healthy periodontal, I mean, a regular healthy dental patient. They are a periodontal patient. They are more susceptible to periodontal breakdown, and so they need to have more frequent cleaning visits or perio maintenance visits. Term referring to continuing care provided by members of the dental team. So we call it continuing care, and that's exactly what it is. We are continuing the patient care um, for the lifetime of their dentition. The interval that we select, 3-month perio maintenance, is the most common. It's shown that approximately every 90 days, the bacteria have built up enough that they need to be professionally dislodged or disrupted in order to stay healthy. So 3-month perio maintenance is the most common perio maintenance interval. However, there are times that we might go longer than 3 months to maybe like 4 months, but we never should be seeing a perio patient every 6 months. It's extremely common that you will hear patients say, well, my insurance only covers it twice a year. Can I just do twice a year? And the answer to that is no. Now, ultimately, the patient's going to do what the patient wants to do. But what you recommend is what you should be doing, and that is every 3 months. The term periodontal maintenance applies specifically to treated periodontitis patients. It includes all measures used to keep the patient's disease under control. The essential element of successful periodontal therapy is the perio maintenance program. So if we do all of our scaling and root planing and everything we possibly can do for the patient and send them on their way and never see them again, chances are they're going to break down. They need more continuous monitoring. So it's key to ensuring periodontal tissues are maintained in a state of health. With good maintenance, patients can retain their teeth or implants in function and comfort throughout their lives. Unfortunately, the disease does tend to recur, and the dental hygienist is the main provider for the phase of treatment. So should a patient ask you if they can go from 3 months to 6 months, it's important that you explain to them why 6 months is not adequate, about the recurrence of disease. Every 3 months, we are able to more closely monitor their progress as far as disease state goes. If we don't see them for 6 months, we're pedaling backwards oftentimes. We're treating disease. It's, to me, just like anything in healthcare, it's better if we can prevent than treat. What are the goals of perio maintenance? The goals of perio maintenance are very well defined: to minimize the recurrence and progression of periodontal disease, to reduce the incidence of tooth loss, to increase the probability of detecting and treating other oral conditions, and to maintain the dentition throughout life of the patient. It's a team effort, so we need the patient to be on our team. We do not want to be fighting with the patient as far as trying to constantly convince them that they need to do these things. We need for them to be on board, and so we need to do an excellent job at explaining to them the disease process and how the disease is managed but not treated. Phases of periodontal therapy. This just outlines the phases. Successful maintenance requires active participation of the patient, the dentist, and the dental hygienist. We are a team working together. We all have the best interest of the patient in mind, and that's to maintain their dentition throughout their life. It should be be adjusted to fit the needs of the patient. So if the patient does have special needs that require adjustment to what our regular successful maintenance program might be, we need to make those adjustments for the patient. So following non-surgical therapy, we do a reevaluation. And at that time, we may need to do an initial therapy or surgery. But for most patients, perio maintenance begins at this time. Biofilm removal must be done at regular intervals. So when you see a patient for a reevaluation, it is just like seeing a patient for a perio maintenance. So at the reevaluation, we're going to reassess everything. Assuming everything is stable and where we want it to be, we're going to put them on a regular perio maintenance program. That's when it's important for you to explain to the patient why we're going to this next step. Procedures performed during the maintenance, update their medical history, patient interview. So when I say patient interview, open dialogue with the patient about periodontitis, about their health, about what they've been doing, and answering any questions they may have. Clinical assessment, so you're going to basically gather all your data. Evaluation of effectiveness of patient self-care. Some of that's going to be done in the patient interview. So let's say the patient said, I'm going to stop smoking. During the patient interview process, you may check in with the patient and see how that's going. How's the quitting smoking going for you? And evaluate from there, how effective is that being for the patient? You're also going to have them talk about what they're doing for their home care as far as their teeth. Again, open-ended dialogue. Don't say, are you flossing every day? Yes or no. You want to say, what are you doing every day to take care of your teeth? Tell me what it is that you do. And from there, you're going to be determining if that's an effective plan for that patient. Identification of treatment needs. So if they need any additional treatment, whether it's periodontal treatment or whether it's restorative treatment, or maybe this is the time now that they want to go have an orthodontic consultation, or whatever the case might be, this is the time to do that. Periodontal instrumentation, so you're going to scale their teeth and polish. Patient counseling, so this is a time to talk to your patient about that quitting smoking. They're at a high and risk for caries, so let's talk about nutritional counseling, things like that, and application of fluoride. So clinical assessment during maintenance, perform a thorough clinical assessment. Gather all your data. That's going to include in your periodontal exam probing attachment levels, furcation involvement, do a plaque index, assess their calculus, their bleeding, mobility, and then if they have any mucogingival involvement. In other words, any places where they have thin attached gingiva. And you're going to evaluate their self-care. So when you're talking to a patient and you're evaluating their self-care, one of the important things to do is to stay on a positive note. So you're going to use your disclosing solution and get a plaque score. But when you're talking to the patient about it, first of all, if you don't acknowledge it, you don't do a plaque index, you don't talk about home care, the patient's going to perceive it as not important. So disclosing solution is helpful. It shows the patient areas they're missing. Be positive and motivational. So nobody wants to come in and get beat up. Let's say they've cleaned every tooth in their mouth thoroughly, but they miss one area. You're going to focus on that area to improve, but make sure you acknowledge all of the good areas that they have. Keep them motivated. You know, it's like getting a 96 on a quiz and dwelling on the one you got wrong. So look at the positives, you know, or they may have plaque in their entire mouth except their two central incisors, and you're going to say, wow, you're doing a great job on these two front teeth here. Now let's try and work on the rest of your teeth the same way. Be positive. Biofilm accumulation. You may want to adjust their self-care techniques, introduce new interdental aids as needed. So maybe you might have them come back and find that you gave them good instructions on flossing, but they just can't do it, or they just won't do it. And if they won't do it, then you need to find something else that they are willing to do. It may not be as effective as the interdental aid you chose, but if they're not doing that, then we need to make adjustments. Identification of treatment needs, so you're going to make sure that they have that their restorative treatment is all complete, that their periodontal status is stable, selective polishing, local delivered antimicrobials, that would be like placing a Reston, or perhaps you're going to irrigate with something. Periodontal instrumentation, the goal is to create an environment biologically acceptable to the tissues of the periodontium. So periodontal instrumentation, we do not need to scale really hard and use heavy pressure in areas where there's no calculus detected. You want to dislodge biofilm. Biofilm dislodges very easily. So we don't need to scale and scale and scale on cementum or on dentin if there's no calculus present. If the patient has a dental implant and there's no calculus present, you can use plastic curettes, or you can use light pressure with your titanium instruments. We want to conserve as much of the root structure, as much of the cementum as possible. Patient counseling, reinforcement of motivation for biofilm removal, smoking cessation if needed. We can talk about other risk factors they might have, nutritional counseling, especially if they're in a high-risk caries group, and application of fluoride. Fluoride helps to promote remineralization. So after we've scaled and we are able to thoroughly observe and see if they have any incipient decay or anything like that on radiographs, application of fluoride in the office. Office guidelines for planning perio maintenance. If you're in a general practice and you have previously treated patients for mild chronic periodontitis and they have a stable dentition, then you can go ahead and continue to treat them every 3 months. If you have a patient that's been to a periodontist, or you think they need to be seen by a periodontist, you can alternate their visits with the periodontist every 3 months. Perio maintenance should receive in a periodontal office if the patient has severe chronic periodontitis or aggressive periodontitis. So if the patient is losing ground quickly, it's time to get them in a perio office. Frequency of visits are on an individual basis, but the studies do indicate that after debridement, gingival pathogens return in about 9 to 11 weeks, which is how we established the 3-month perio maintenance interval. Your patients should not be going back to every 6 months. So when it says determined on an individual basis, when the patient comes in and says, well, my insurance only covers cleanings twice a year, so can I go back to doing my cleanings every 6 months? And the way I always responded to that was that, they'll say, well, my periodontal condition's been fine. I haven't had any problems for 2 or 3 years now. Can I go to every 6 months? My response to that always was, obviously they can do whatever they want. My recommendation is to stay on every 3 months. It's possible that the reason you have not had any problems for 2 or 3 years is because you've been coming in every 3 months. And so usually that kind of gets the patient starting to think. Recurrence, disease recurrence, the return of disease in a patient who has been previously successfully treated. So the patient had treatment, they had a good result, they're a stable periodontitis patient, and then they break down again. That's disease recurrence. Despite having received excellent treatment, treated periodontitis patients are at risk for recurrence of periodontitis for the rest of their lives. And that's a good baseline conversation to have with your patient at the re-eval and to help reinforce the need for 3-month perio maintenance. They are at risk for recurrence of periodontitis for the rest of their lives. The signs and symptoms of disease return after having subsided. Recurrence implies that periodontitis was brought under control during non-surgical therapy. Clinical signs of recurrence. Progressive attachment loss is basically the main one. You do your probing depths, you measure your clinical attachment, and you determine that their attachment loss is progressing. Other things you can see is radiographic evidence of progressing bone loss or increased mobility, pockets getting deeper, pockets that bleed on probing or exhibit exudate that did not previously bleed on probing is a sign that inflammation has returned. And remember, inflammation that's not controlled progresses to attachment loss. Reasons for recurrence. Inadequate self-care by the patient is usually the number one reason. So the patient was doing everything they were told to do for the first few months or few years maybe, and then they start slipping. Failure to control systemic factors is another one. So the patient becomes ill. It can even be like a one-time illness. So the patient gets a really bad bout of the flu and can't brush their teeth and can't floss their teeth for a while. They're going to show some attachment loss. Situations like that sometimes can be reversed. So you'd have to kind of do a little bit more questioning to figure out what to do. And then the other one is attempting to treat teeth with a poor prognosis. Patients do not want to lose teeth. And so we might have tooth numbers 2 and 15 that have 8mm and 9mm pockets on them. But the patient says, I don't want to lose those teeth. I'm just going to hold on to them for as long as I can. So for a while they do, but then we start to see breakdown on number 3 and number 14. And that's the time to say, okay, we're treating teeth that have a poor prognosis, and therefore now we're going to start to have problems with teeth that had a good prognosis. Refractory disease, on the other hand, is when periodontitis that is resistant to control even with appropriate therapy. So the patient has done everything possible, you have done everything possible, but we still can't control the disease. Difference between recurrence and refractory is that recurrence is a return of the disease. Refractory, we never got the disease under control. And how do we manage recurrence? Well, for starters, we can retreat, but first we need to make sure that they're doing everything appropriately at home. If they're not, then we need to work on retraining the patient. So the patient had scaling and root planing, and you went over all your self-care, and then the patient goes home and comes back a few months later, and they still have a lot of plaque. They still have a lot of buildup of calculus. They still have inflammation, bleeding on probing, all the signs of disease are still there. So what do? First, we start with evaluating their self-care. And let's say we determine that what they were doing is inadequate. Then we need to go back and retrain that patient on some new home care techniques and try to see if we can't turn it around that way again. Failure to comply with the schedule is another biggie. So a lot of patients, even though you've told them and expressed the importance of 3-month perio maintenance, they decided they couldn't do it. And they decided to wait 6 months because that's what their insurance is going to cover. So we will continue to see those patients not get better if they stay on a 6-month recall. Disease appears locally. So they've had a good result with their scaling and root planing, and they've been managing their disease okay, but unfortunately they have a few areas that maybe the pockets were deeper, maybe their home care there is not as good, it's harder to reach, tighter area. So we can do localized scaling of root planing in that area again and retrain them on their home care. Patient compliance. So patients are not always compliant. I know that might surprise you, but patients do not always do what we tell them to do. A patient who does not follow recommendations is non-compliant. A patient who follows our recommendations is compliant. So some of the reasons for non-compliance are different for each patient. Sometimes they're fearful of the dentist. Denial of the disease is an extremely common one. You can talk and talk and talk about a disease to the patient. But remember, periodontitis is chronic. It happens slowly over time, and it's often, or most of the time, not accompanied with pain. So the patient can't see it, they can't feel it, and so therefore it doesn't exist. And so denial is a difficult one and a huge one to overcome with patients. Failure to understand the implications of non-compliance is another one. It is your job as a dental hygienist to explain to the patient what needs to be done, but to also explain to the patient the consequences or implications of not doing what needs to be done. And I'm not saying you have to be threatening or mean to a patient by any means, but the patient needs to understand that if they don't do these things, this is what could result. And even if the end result means loss of their teeth, they need to understand that. Oftentimes it becomes a low priority to patients. So in other words, the patient has so many other things going on in their lives or so many other things they need to pay for that dental treatment slips low on the priority list. So it can be health issues too. Maybe they've got other health conditions. They're trying to manage and control that diabetes. And so dentistry tends to slip lower down the list. They have children that have needs. They only have so much money they can allocate to dental expenses. And so those things all have to be dealt with. Strategies for improving them: give them things to take home if you can. Printed instructions. After you've had the patient, especially during a scaling and root planing appointment, after you've had the patient in the chair for an hour and a half and they're numb and their face feels like it's 4 times the size it should be on one side, they're done with you. They've checked out and they're ready to go home. And so oftentimes that's not the best time to do self-care. In fact, I normally did my home care instructions after I did my data gathering, is the time to do your home care instructions. Because by the time you're done scaling and talking and an hour has passed, patients are ready to go. They've got to get back to work. They've got to get back home to their babysitter. They've got things to do. And so they've stopped listening to you. If you can give them something printed to take home with them, they're likely to open it up later and look at it. Simplify the recommendations. Don't give them 15 oral hygiene aids with 10 minutes of instructions for each. Keep it simple. Limit the recommended number of self-care aids. Don't give them 15 things. Pick the most important things and go with a couple of most important things and go with those things. Make sure you listen to their concerns. If they tell you that they're concerned about something and you totally ignore it, they're not going to listen to you. And accommodate their needs if possible. Make sure patients understand the disease and the disease process. Monitor appointments that are missed. So if your patient has missed their last 3 appointments, you might want to at least acknowledge that during your appointment time. Sometimes patients miss appointments because they have other really important things going on. And if you acknowledge that they've missed some appointments in a nice way, showing concern for why they've missed the appointments, oftentimes they will open up to you about why they missed appointments. And those missed appointments, or those reasons they missed the appointments, might help you to make adjustments to their home care or other adjustments to their treatment. It might help you to understand the patient better. Provide positive feedback. point out the areas of improvement, be a cheerleader for them, compliment the patients in front of the dentist. Tell the dentist what a good job they're doing on their home care if they are. Root caries, periodontal patients are more susceptible to root caries because of the exposed cementum and dentin. So often your patients will have to use a home fluoride. So be looking for root caries lesions. This is a picture of what root caries can look like. We know how to check for caries. This will be visible as well. So home fluoride treatments might need to be done. A toothpaste that contains fluoride. They have mouth rinses that contain fluoride. We can apply fluoride in an office. They have fluoride in their drinking water. So make sure that they don't have xerostomia and that's causing the problem. If they do, then we have to boost up their fluoride intake. If they do have xerostomia, xylitol containing gum and lozenges are appropriate for that patient. Caries risk determination. If you find a patient that has or is at a high risk for caries, talking to them about the use of fluoride is a good way to start. Risk groups, they have a high risk, moderate risk, or low risk. You have some caries assessments you're going to do to practice or get started on the idea of caries and how to assess it. So fluoride in the toothpaste, fluoride in the water. There are home fluoride rinses such as like Act fluoride rinse. We have Prevident fluoride rinse available. There are generic forms of Prevident. Patients, since fluoride rinse, fluoride toothpaste can be prescription. Oftentimes patients would like it prescription so that they can get it covered on their prescription card to make it less expensive. So work with the patients on those kinds of things. But always be paying attention to fluoride, to caries. Patients who are at an extreme risk for caries, these are some of the products that are available to them. I mentioned Prevident. Prevident has a rinse and a tooth gel in different various dosages. Durafat's another one that's made by Colgate that can be applied in the dental office. So just kind of see, MI paste is another one. There's all kinds of products out there. And so when you get in private practice, you will learn about the products that you have available in your office. And you may want to recommend or change those products if your doctor's open to it.